Welcome to Link 2025. I am Emanuele Orru, a neurointerventional radiologist at the Levy Hospital and Medical Center in Burlington, Massachusetts, and I have the great pleasure and honor to be here today with Professor Elad Levy, Chairman and Professor of Neurosurgery at the University of Buffalo, and successor to the great late Nick Hopkins. Elad, thank you so much for being here today with us. And what we're going to discuss about today is this new concept of ambulatory neuroendovascular treatment for brain aneurysms. Elad, would you mind introducing the concept to the audience?
Sure. As you may or may not recall, in the 80s and 90s, everybody got their imaging in the hospital. Today, we do endovascular procedures, and the patients stay overnight, whether they need to or not, and go home the next day. So we ask the question, why can't we do this in an ambulatory setting, like we do knees and hips? Why can't patients have their aneurysm treated endovascularly, and if they're doing well, go home the same day?
Yeah, very thought-provoking. And do you think this applies to all aneurysm patients, or do you implement selection criteria for this?
Yeah, so we looked at our 2,000 patients that I treated, and based on that, we said, patients who have straightforward anatomy, there's no simple patient, but anatomy that's not too tortuous, in patients that are healthy without too many comorbidities, can we do a straightforward flow diversion in an outpatient center and send them home the same day?
And when you discuss this with patients, do you give them the option of doing it in the conventional way with a hospital stay and all the usual procedure, and to do it in this new, different setting?
That's a great question. So the first thing we discuss is, would you like to do it awake or asleep? We spend 10 years publishing doing this under conscious sedation with a lower complication rate, or at worst equal to conscious sedation. And most people don't want anesthesia. There are some that say, doc, please put me to sleep. I don't want to be awake. The second question is, do you want to be done in a major medical center downtown, where you may get canceled by subarachnoid hemorrhage or stroke or other emergencies, or in a more boutique setting in the community with a more concierge feel? And again, not all, but most patients prefer the concierge feel.
I see. And you just mentioned one point of discussion which I think is very interesting, anesthesia. So something that may discourage operators even from doing this is this concept that maybe this is better done awake in an ambulatory setting. So I have two questions in this respect for you. Do you think the utilization of general anesthesia is, blocks the idea, or is something that doesn't allow the procedure to be performed in the ambulatory setting? And when you do your patients awake, do you have anesthesia availability right there?
Two great points. So no, if you feel comfortable doing it asleep, most ambulatory centers do asleep surgery, whether it's cervical spine or knees or hips. So you can do it asleep. And the other point is, for safety reasons, you have to have anesthesia on standby. If we haven't had the problem, but if you need anesthesia, you have to be able to rapidly intubate the patient.
Yes, absolutely. I completely agree. Well, let me segue to safety. But now, all of this obviously sounds great, but do you have data to support all these, great ideas?
So baby steps first. So the first thing we did is we looked to our radiology colleagues, our vascular colleagues, not in neuro, in the body, and said, what do you do outpatient? What lessons can we learn? Then we published about 70 cerebral diagnostic angiograms. Again, is it safe to do even cerebral angiography? Get the team used to do it in an ambulatory center. No major complications, one transient vision, again, maybe from dye reaction. And then we recently published in JNIS our first series of paraclinoid carotid aneurysms using flow diversion without complication. Again, highly, highly select patients. Small steps until we think we can expand the patient base and make this more ubiquitous.
Well, let's make a slightly bigger step. What do you think is the future direction of this, and the expansion of this idea to other procedures perhaps?
So you're hearing this first in Link 2025. There is no question in my mind that this will be expanded from a cost basis, from a patient preference basis, from just scaling for where you need to have room to operate. It needs to be done by physicians that have a lot of experience, years of experience, who also have good relationships or perform cases in these quaternary centers.
And so, again, to connect with what you just said, it is most likely that hospitals that would decide to implement this in a stepwise fashion should be probably hospitals with high experience, large volumes, and very, very long history of performing these procedures in the conventional setting.
Exactly. This is not your first shot out of the barn. Build the practice, build the team, build the relationship with the hospital, and this should follow.
Well, thank you very much, Elad. I think this was, a great pleasure to have this discussion for you. It's very thought-provoking. I'm sure that this is maybe the first time we talk about it, certainly not the last, and it will be talked about a lot in the future. But I have one last question. Is this the future?
Thank you, Emanuele. It was my pleasure to be here.